So hello everyone. Thank you for attending, and good afternoon or good morning, depending on your time zone. It's a pleasure to present as part of the ILAE Young Epilepsy section and the EMR region. So we're presenting this article, which you'll be seeing soon now. And our presenter is Dr. Faye Abdul Ghafoor, who is a senior resident here in Kuwait. And we have also Dr. Yusuf Al-Najjar, who is an epileptologist also here in Kuwait in Jabr Hospital, supervising as well. So Faye, if you're ready, you can go on and start presenting.
Okay, thank you so much, Dr. Badr. And thank you everyone for this opportunity. Today I'm going to be discussing non-convulsive status epilepticus diagnosis. We're going to be defining electroencephalographic and clinical response to diagnostic intravenous anti-seizure medication trials. So this is the paper that I'm referring to by Marcus Leitinger and his colleagues. Okay, so firstly, non-convulsive status epilepticus can have severe outcomes, including very high mortality rates. The diagnostic criteria for non-convulsive status epilepticus have emerged, notably from the Salzburg Consensus and the ACNS Standardized Critical Care EEG. Terminology, which encompasses the utilization of IV anti-seizure medications to ascertain both electroencephalographic and clinical responses. Notably, absent from the existing literature, however, are clear operational guidelines on how to conduct this diagnostic anti-seizure medication trial and subsequently evaluate responses, which represent a crucial gap in clinical practice. Okay, so this paper used a Delphi process. It involved 6 experts in the field. They were utilized to reach consensus on best practices. This involved discussions about diagnostic criteria, the choice of medications, dosing strategies, and response evaluation. Recommendations were intended for patients clinically suspected of having non-convulsive status epilepticus, characterized by EEG patterns consistent with possible electrographic status epilepticus. So what is the Delphi technique? It is the systematic process of forecasting using the collective opinion of expert panel members. It is practical in problematic areas where either statistical model-based evidence is not available, knowledge is uncertain or incomplete, and human expert judgment is better than individual opinion. The vital elements of Delphi methodology include anonymity, iteration, controlled feedback, and statistical stability of consensus. So this is how it's done. First of all, there's a problem area. There is systematic identification of the problem. And then there are panel members, selective based on objective and a predefined criteria. And then they do the Delphi rounds. So there's anonymity of panelists and responses. There's controlled feedback, and there's iterative rounds. And finally, there's closing criteria, where there's a consensus criteria, analysis of the consensus, closing criteria defined a priority, and stability of results. Okay, so just a few definitions before we proceed with, the findings of the paper. An electrographic seizure, epileptiform discharges averaging more than 2.5 Hertz for more than 10 seconds. Or more than 25 discharges in 10 seconds. Any pattern with definitive evolution as defined above and lasting more than 10 seconds. An electrographic status epilepticus is an electrographic seizure for more than 10 continuous minutes or for a total duration of more than 20% of any 60-minute interval period of recording. Now, this is what the paper mainly focuses on, is the ictal-interictal continuum. So this is when patients don't really meet the criteria for electrographic status epilepticus. So possible electrographic seizure and possible electrographic status epilepticus. It's a purely electrographic term. It is not a diagnosis. It is a pattern that does not qualify as electrographic seizure or status epilepticus. However, it may be contributing to the patient's impaired alertness. It's potentially ictal or interictal. Ictal meaning it is contributing to the patient's symptoms. Interictal means it is unlikely to be contributing to the patient's reduced or impaired alertness. Any periodic discharge or sharp wave pattern that averages more than 1 hertz and less than 2.5 hertz over 10 seconds, or more than 10 and less than 25 discharges in 10 seconds, or a pattern that averages more than 0.5 hertz and less than 1 hertz over 10 seconds, or more than 5 and less than 10 discharges in 10 seconds, and has a plus modifier or fluctuation. Lastly, any lateralized RDA averaging more than 1 hertz for at least 10 seconds at least 10 waves in 10 seconds with a plus modifier or fluctuation. And of course, it should not meet the electrographic seizure or status epilepticus definitive criteria. So the paper basically recommended that the patients could be started either on non-benzos or benzos. They recommended using non-benzodiazepine if the patient had impaired alertness or risk of respiratory depression. Benzodiazepines were used in incremental doses. The initial dose of the IV anti-seizure medications should be 2/3 to 3/4 of the maximum loading dose used for convulsive status epilepticus. If there was no response, the last third or quarter should be administered. For the EEG recording, 2 different criteria were recommended, either a 15-minute monitor or for 30 to 60 minutes for medications such as phenytoin and phenobarbital. They looked at the response in 2 different ways. They looked at it via EEG response, and they also looked at it from a clinical response. So this was the EEG response. With the ictal-interictal continuum, patients could either have a continuous EEG ictal-interictal continuum, or they could have a prevalence of 60%, or an interrupted ictal or interictal continuum. So these were the 2 different scenarios in which they monitored or suggested that the anti-seizure medication did have a response, i.e. that the IIC was truly contributing to the patient's impaired alertness. The first scenario is in the case of continuous ictal-interictal continuum. After giving the anti-seizure medication via IV, a break of 1 minute is regarded to be caused by the IV anti-seizure medication, meaning that this IIC is likely contributing to the patient's symptoms of impaired alertness. Scenario number 2 is when the IIC is interrupted and non-continuous. Here, the experts decided that in cases with a prevalence of less than 100% of IIC, the break is regarded to be medically induced if its duration exceeds 3 times the longest spontaneously occurring break. For example, in B, the naturally occurring gap, the longest naturally occurring gap was of 15 minutes. So a break of 45 minutes, which was 15 times 3 of continuous medically induced break, was considered to be relevant. And in the first scenario, where it was continuous, a break of 1 minute was considered to be relevant. Next, they developed a clinical response scale, the NRS, for measurement of clinical improvement in response to IV anti-seizure medication. Level 10, the patient becomes completely normal, whereas level 1, there is no purposeful response to painful stimuli. And this way, the patient can be clinically, objectively evaluated, where you have a clinical response level of prior to giving the anti-seizure medication or the benzodiazepine, and then we can measure their response and give them an objective level after. This was the recommendation for the benzodiazepine initial doses. So they used midazolam, lorazepam, clonazepam, and diazepam. The starting dose for midazolam was 1 mg. For lorazepam, it was half a mg. For clonazepam, it was a quarter. And diazepam was 4 mg. And like we said, if there is no EEG response, we give incremental doses. It's the same as starting doses every 2 to 3 minutes up to a maximum dose of whichever is lower. So the maximum dose for the midazolam was 0.2 mg per kg. For the lorazepam, it was 0.1 mg per kg. For the clonazepam, it was 0.05 mg per kg. And with the diazepam, it was 0.25 mg per kg. The maximum dose, as you can see here, was 5, 2.5, 1.25, and 20. For the anti-seizure medication, like we said, you either use 2/3 of the maximum dose or 3/4 of the maximum dose. If there was no clinical response, you would use the remaining dose. With the levetiracetam, the starting dose was 40 mg per kg, valproate was 30, lacosamide 6, brivaracetam 4, fosphenytoin 15, phenobarbital 10. The maximum total loading dose is 4.5 grams, 3 grams, 600 milligrams, 450 milligrams, and 1.5 grams and 1.5 grams. And like we said, different medications had different EEG monitoring periods, with fosphenytoin and phenobarbital having 30 to 60 minutes in comparison to the others where it was recommended to have 15 minutes EEG monitoring. So to conclude, this is an overview of the diagnostic IV anti-seizure medication trial recommendations. Background rules: if the baseline EEG background frequency is known, a return to baseline or appearance of previously absent normal features in patients with no acute neurological or systemic conditions that can affect the background activity, normal background or appearance of previously absent normal features. In all other cases, the criterion cannot be applied. So as we can see here, we start from the top. So if we have a clinical suspicion of non-convulsive status epilepticus, we do the EEG. The EEG shows possible electrographic status epilepticus, i.e., for example, in our case, it can be the ictal-interictal continuum, where the patient's EEG pattern does not specifically meet the criteria for established electrographic status epilepticus. We can give a trial, either of a benzodiazepine or a non-benzodiazepine. We mentioned that if the patient has impaired alertness, it is better not to use the benzo and better to use the anti-seizure medication. So the two factors are impaired alertness and respiratory depression. If the patient is at risk of either or has either, we will go with the non-benzodiazepine trial. So with the benzodiazepine, we start at incremental doses. It was suggested that the first choice would be midazolam. We do this in small incremental bolus doses every 2 to 3 minutes under EEG and clinical surveillance. In case of failure, we reach the maximum dose. Okay. In case of failure of the benzodiazepine, we then proceed with a non-benzodiazepine. So either for benzodiazepine failure, or if patients are at risk of respiratory depression or at risk of or have impaired alertness, we go straight ahead with a non-benzodiazepine trial. The fast four is levetiracetam, valproic acid, lacosamide, and Briviact. So like we said, we either give initial dose of 2/3 to 3/4 of the maximum dose. If there is failure, we proceed with the maximum dose, i.e. the rest of the remaining dose. In case of failure, we can do a second trial of a non-benzodiazepine, or we can go with the benzodiazepine trial. And then we have to have the minimum observation times. Like we said, for most of the medications, it's 15 minutes. For fosphenytoin and phenobarbital, it's 30 to 60 minutes. And then we have two ways in which we can decide whether this patient's EEG pattern of IIC is actually contributing to the patient's impaired alertness. Firstly, via EEG, secondly, via clinical response, depending on the level of alertness. So at least one step improvement on the NCE response scale, the one that we mentioned, levels 1 to 10, or a definitive time-locked improvement in a focal deficit. Secondly, the EEG response, if there is no interictal continuum 3 times the longest prior spontaneous IIC free interval, that's a mouthful to say, but minimum of 1 continuous minute. This guides us to the EEG response. In non-comatose patients, we have the background rules. In comatose patients, like we said, either if there was a continuous IIC, there is a 1 minute medically induced break. If there was a non-continuous IIC, we take 3 times the longest break in EEG pattern, i.e. in the example that we mentioned previously, it was 15 minutes. So if they have a 45-minute break in the IIC. Lastly, the strengths of the paper, the expert consensus approach validates the clinical relevance of recommendations based on a collective body of knowledge. It establishes clear guidelines that can improve diagnostic accuracy in non-convulsive status epilepticus cases. It provides a clear framework to base further studies on. In terms of limitations, the Delphi group consisted of only 6 experts, indicating that further validation will be necessary to generalize these recommendations widely. The practicality of implementing the proposed scales in various clinical settings has yet to be assessed thoroughly. The expert panel mainly was from the US and Denmark. There's weak representation from other parts of the world, such as the Middle East. It was unclear if there was anonymity during this process. And that pretty much sums up my talk and summary of the paper. Thank you so much.
Thank you, Dr. Faye, for the excellent presentation. So if anyone has questions, you can type them at the bottom there. There is a chat function where or a Q&A function where you can type in your questions. So I'll see if there's any questions. So one question is, what is the criteria for non-convulsive status epilepticus based on the EEG? Dr. Faye, do you think? I think it was mentioned in the presentation early on, maybe, right?
Yes, so we can go back to the definitions here. So here we go. So an electrographic status epilepticus. So it is an electrographic seizure. Can you hear me? So it's an
Yes.
electrographic seizure for more than 10 continuous minutes or for a total of more than 20% of any 60-minute period of recording.
So another question is, for how long after the initial 15 to 30 minutes during which we expect an EEG improvement should we wait?
So it depends on the drug. I put here. So for most of the drugs, it's 15 minutes, with the exception of phenytoin and phenobarbital. You wait 30 to 60 minutes. That's this part here.
Yeah, so it depends on the drug being given. Yeah, and let's see. So there is one comment mentioning that they do not see the rationale of increasing doses instead of full dose. Keeping in mind that non-convulsive status will have a detrimental consequence on the brain. So I think the incremental doses is mainly in the benzodiazepine class. And I think part of the reason they do it incrementally is to avoid in patients who are not ventilated, for the safety of the patient, they may go into respiratory depression, and it provides a more structured way to assess the response. So another question is, if stopping the status is an urgency, why don't you start directly with the maximum dose of each drug? Why a step-up approach? So again, I think...
I can answer the question if you wish.
Yes, go ahead, Dr. Yusuf.
Yeah, so basically everyone knows the mortality of non-convulsive status is really high. is up to 39% over 30 days. And with that being said, the data that we have for anti-epileptic medication response is extremely low for EEG improvement and clinical improvement. The data is about like 12%, and with only EEG improvement is 7%. So back to the question. Basically, this study is kind of paved the way to show how we carry out the performance of giving anti-epileptic seizures, because it's not well defined in the literature. So is there any hierarchy whether to use benzo, non-benzo? And there's a difference among anti-seizures medication. And what's the preference medication that we should use? This has not been answered in the past. So basically, this study is kind of touch very softly on the fact, how do we carry out the anti-seizure medication since it's a part of the non-convulsive status criteria.
Thank you. So another question is, if there is no improvement within this duration of follow-up, would you stop EEG recording afterwards? So I guess that depends on the... You can go ahead, Dr. Yusuf, if you'd like.
Yeah, sure. I mean, ideally, we would like continuous EEG recording and escalate on the anti-seizure medication, right? And to see the improvement and to confirm your suspicion about non-convulsive status. But doing routine EEG, there is a hiccup with it because it only records like short time, which you might not have the definitive answer of improvement. So the more you record is better.
Yeah, and I think they mentioned in the paper also that the response and the ecto-interictal continuum can be noted even after 24 hours from the anti-seizure medication trial, although it would be difficult to assess if this was due to the medication or not at that point. But for sure, an hour, I would say maybe 2 hours would be more than enough in most people. So if a patient has impaired awareness and EEG is showing generalized triphasic waves of 1 to 2 hertz, can we call it as an IIC? And does that justify the midazolam challenge test? So this is a very common scenario we come across in patients with triphasic waves. They can occasionally be very frequent, and yes, you could definitely call it an IIC pattern if they're in that frequency. And we would administer either midazolam or an anti-seizure medication to see the response. And this, the benefit of this paper is it gives us a structured way to go about this. Another question is, what is the clinical manifestations in non-convulsive status epilepticus? Is it possible in an oriented patient?
The clinical manifestation is variable. It can be anywhere between stuporous patient, comatose, to a patient only have impairment of working memory. So it depends on the clinical presentation, because you have to define at the beginning what's the change of the patient's mental cognitive status.
So there's a question, any way to distinguish between triphasic waves and periodic lateralized epileptiform discharges?
I guess some people, as you mentioned, Dr. Bedi, they might consider triphasic waves as a subtype of generalized plaques, and other people don't. So there is no 100% agreement on the matter. But you take things into the clinical context. That's the best thing to do.
Okay, so if there's no more questions, I would like to thank the speaker, Dr. Fay and Dr. Yusuf, for joining us, and I would like to thank everyone who attended. Thank you very much, and we'll. I think there's one more question. We'll take one more question and then we'll stop. So it says, should we consider continuous spike and wave during sleep? I don't understand.
I
So
mean,
continuous spike wave during sleep would be different from the. It would be different from the IIC.
It's
Dr. Yusuf,
actually,
you can go ahead.
yeah, sure. So part of the ictal continuum is there's a variable pattern, either is rhythmic delta, right, or pleds, or spike and wave. With the spike and wave, you have to, if it's less than 3 hertz, you have to have changes in the spike and wave morphology and subtle changes of frequency, at least 0.5 hertz, and it have to be spread in the space like to attachment, EEG attachment at least. To consider this might be a suspicion of ictal interictal continuum.
Okay, last question would be, do you give anti-seizure medication if generalized periodic discharges of triphasic morphology are present? So yeah, definitely so as we know, triphasic waves have been classified under generalized periodic discharges, and if you have GPDs with triphasic morphology and they're frequent and they're within the frequency range of the IIC as mentioned, so 1 to 2.5 hertz, and you think patient obviously would not be completely alert, then you can consider yes, you should give anti-seizure medications to know if this pattern that is falling within the IIC is contributing to the patient's clinical status. Okay, I think we'll leave it there. Thank you everyone for joining, and take care.